Thank you, Matthew. I'm going to kick-start this morning and follow off from the conversations with Michael and Kieran today by putting a little bit of meat on the bone when it comes to form, function and future of healthcare. I have worked in the NHS in senior capacities. I've also worked in local government in senior capacities and a variety of management consultancies over the years, and worked in the private sector too. And I'm going to talk about something that I think is really important, which is about having purpose to what you do and how you do it. Because if you have that, then we can all be passionate about it and achieving the right aims and objectives and goals that was mentioned this morning. Form, function and future, I'm going to focus on one aspect of the healthcare system, ecosystem, which is intermediate care. I was talking to Connor just now about that. It's an amorphous mass and in many ways an amorphous mess, and it doesn't need to be. And I'll explain as I talk. So I'm going to try and do four things in the next 20 odd so minutes, hopefully, which is outline a bit of background and context and theory of change, because that's really important. Without understanding theory, you can't scale anything. How you effectively go about researching and studying healthcare organisations, because we don't do that well. And then how you practically improve in healthcare or public services, or indeed in any service environment. I'm going to offer some conclusions and reflections towards the back end. So to begin with, this is the national picture. I call it the squeezed balloon metaphor. We've had it for some considerable time now. On the left-hand side, we are paralysed in many ways by challenges around demand and capacity. There's too much of one and there's too little of the other, is the common perception. On the other side, we're also then struggling with, ever since austerity, which was mentioned today, since 2008, really, we've been in a world of stagflation and stagnation, and there isn't enough money. Although that's not strictly true, because in the NHS now, we spend about £215 billion is the current figure, and that's gone up considerably in the last 20 to 30 years. Whether that's all been money well spent is the other side of the equation. And then performance. Now, you will hear reference to politicians being made throughout the course of the next couple of days. It was relenting. We've got real challenges about whether we're measuring the right things and then doing the good work off the back of them. So that's the background context. I said I'd talk a bit about theory. My work and the work I choose to do challenges convention. Convention is on the left-hand side. It's how we conventionally think about understanding, managing and improving healthcare or public service systems. I call it activity obsession disorder, because it starts with a focus on trying to understand performance problems in whatever area through the lens of work activity. Off the back of that, we then try and manage that activity up or down, depending on where you are in the healthcare landscape. In accident and emergency, it's about how do you get those numbers down. In elective care, it's about how we get those numbers up. And we struggle to do either of those things. And then adding insult to injury, we overlay all of that with activity metrics called targets or KPIs. And they add even more distortion and confusion to the picture. The consequence of all of that is listed there at the bottom. Worse service, poorer user or patient experience, higher costs, and it reduces and demoralises staff, because that's not what they come to work to do. On the other side is what I describe as humanising healthcare or humanising systems. It's my labour of love, it's my passion, which is my purpose, which is actually, if we step back and ask some simple elementary questions, who are the people causing us to do what type of work activity? Get into that detail about whether we're doing the right type of work or the wrong type of work. Then we'll get to the realisation that we don't need to spend anything like as much money as we are at the moment, and we can all benefit from that. I'm going to give an example of that in the form of intermediate care, to put meat on the bones, to link form to function, and give a view of what I think the future of public services and healthcare needs to represent. Starting point then is, how do you intelligently understand any service, any system, any sector? Well, for me, it's about using a combination of qualitative and quantitative work techniques get the perspective of the person that matters the most, and that is the patient, the service user, the client, the adult, the customer, the resident, whatever label we may give them. Ask fundamentally different questions of data. How many people, how much activity, how much costs, and then start to study the value equation. Start to understand, for the work we're commissioning and the work we're delivering, is it adding value or is it adding waste? Is it work of no value, or are we actually doing what matters to people when we need it and where we need it? This is of crucial importance because we do not study healthcare systems in the way you're about to see, and the consequence of that is worse service and higher costs everywhere. So I'm going to talk about intermediate care. Now, intermediate care, as I mentioned earlier, is an amorphous mass. It was in this part of the world as well, West Essex. It is everywhere. Now, in West Essex, they spent £25 million a year. Some of that work was commissioned by the local authority. Some of that work was commissioned by the NHS on 12 services. I asked the senior commissioner when I came into this system to ask two questions of his leadership group. One, what is it that we spend £25 million a year on that we call intermediate care? And two, how many service users does that represent? So what are we spending £25 million a year on, and whom? The answer was met with a tumbleweed moment, because we didn't know. And that was the starting point. And in this world, they'd spent £7 million on a well-known management consultancy not to answer any of that stuff. I think that's catastrophic. So, cut a long story short, taking the last couple of years, because you need time series data, asking fundamentally different questions of the performance management frameworks, information systems and the like, we discovered that actually in a population of crudely about 213,000 people a year, over 2 years, the service user population, in other words, the people using intermediate care, were about 11,000. In other words, about 6,000 people every year. About 1.4% of the population. Tiny. But the kicker was, how many people were consuming intermediate care versus how much activity or interactions, as it's labelled there? Because you hear a lot in the commentariat, in politics, in national media, that demand is rising exponentially, okay? You're all familiar with that. That's not true. When we talk about demand rising, we mean work activity, because going back to activity obsession disorder, that's what we obsess on. That's what we record, monitor, measure, and report on. When you actually ask the question of demand should be understood in person terms, in patient terms, in service user terms. How many people are using £25 million a year worth of intermediate care? You discover it's a steady state. It's stable, predictable, repeatable, but grossly uneven. Small numbers of people were consuming all the work. Here, the increase in activity was going up by nearly 15% per year. The increase in unique people wasn't. That's helpful to know how you commission, design, plan, and build healthcare and public services. What's also interesting to know, I'm going to come back to that in a few moments' time, is where these people were. They're always geographically clustered. They're not universally spread in any locality. They won't be here, they won't be anywhere. It's the same. I'll come back to Harlow in a few moments' time. The next step is, well, you spend £25 million a year and you've got 12 services, but where do these people go? Where do you pick them up? And what this is showing is a map of all the intermediate care provision on the right-hand side, the intermediate care processing, which is kind of what we do in the world of referrals, and also where the work gets generated. You kind of have to know the what and the why of how the work starts in order to then study people's interactions with the service and the system to understand, are we doing the best possible job we could be and should be for the people who need intermediate care? We looked at over 300,000 lines of data, and that was fusing multiple different data systems, and sometimes data systems in the form of Excel spreadsheets that were kept in people's back pockets just in case. We did a technique called demand analysis, which is to understand, is this a value demand or is this a failure demand? Are we doing the right type of work or the wrong type of work, and how predictably? I'll give the game away now. 70 to 100% of the work was regarded as what's called failure demand, the inability to do something or something right for the service user. Think of that set against £25 million worth of expenditure. And we reviewed all of them, of the vital few, which we're about to see in a minute. You have to go through, speak to other people, understand their journeys, what matters to them. That's the case note review. This is how you start to unlock a really intelligent understanding of performance. Because when you do that, you realise the problem to solve is not the problem you think. They didn't have rising demand here. They had stable, predictable, repeatable demand, but it was grossly uneven. Small numbers of the same people were consuming all the work activity and all the costs. I've highlighted the group that I call the vital few, 5%. Now, this is a truism over where I've been doing this work over several years now in all aspects of public services, in all aspects of healthcare, that it's really small numbers of the same people, in this case 556 unique human beings, who are behind 20% of the work and 30% of the £25 million a year. Now, if we're serious about wanting to start to transform public services and the NHS, where do you start? It's putting meat on the bone of some of those principles you heard today, providing for better service that's tailored to needs. So remove the obsession with standardisation. Standardisation only ever works when the problem to solve is standard patients or standard service users. My question to all of you is, in your respective environments and work areas, how often do you meet a standard anything? We're not. I'm not. You're not. We're all unique. We're all different. So you need to design services for clusters, for patient and service user cohorts. When you studied the work, you realised that everybody went through this cycle, this standardised, automated cycle, no matter whether you had 4, 5, 6 things going wrong in your world or just one problem that we needed to solve. Everything would start with a referral, and you could be parcelled up and from pillar to post multiple times, starting at referral stage. We would then triage you. Triage is a euphemism for trying to stop you getting a service. It came from the battlefield where it was chaotic. You couldn't manage demand because you didn't know, quite frankly, who was getting shot next. We don't have that problem in healthcare. Demand's really predictable, so there's no value to triage. Then assessment. Now, we will parcel you up multiple times. Some people could be assessed half a dozen times or 20, 30 times a year through different service specialty teams. Then we go back into our respective areas and we provide standard work tasks duplicated at every point because we use different systems. We performance report in different areas and we all have different budgets, right? Talked about activity metrics. The name of the game is how quickly can you get someone in, out, bish bang, go. That's not the same as stepping back and understanding what matters. What have we got to do for you? And do it right first time. We might get round to reviewing you, but probably we won't, because at that point we've lost all faith and all hope, and we're all demoralised. And then, to add insult to injury, bearing in mind the cohort group here was 80% were in their 90s and 50% were in their 80s, we'd close your case. The consequence of that was catastrophic, and they were advised to do this by said consultancy. The outcome of that? Horrific. 71% of people having intermediate care were back round via an ambulance into the hospital before 30 days had elapsed. Why? Because we were squeezing the time. Don't give someone 6 weeks if you can give them 2, because we can save on the bottom line. But you look at the total costs of that, they're horrific. What do you do instead? You do this. You jettison that stuff. You start with cohorts of people. For the very first time, we gave them a purpose. The purpose of intermediate care, remember the tumbleweed moment, is right up there. Help me and my family manage our circumstances, solve our problems so we can live better lives, age well, and or provide dignity in death. And that creates your performance measures. They're related to need. Firstly, understand need. Don't obsess on assessment. Let's understand what we've got to do for you and your peccadillos and your nuances and what matters to you. Build one plan, not several. Not parcel you up countless times in referrals, allocations, triaging. Have a coordinated team of people designed based on the needs you have in a geographically concentrated areas to do what we need to do, to care for you, to manage you, to treat you as appropriately. Thirdly, get to deliver the work. Right? We talk an awful lot about planning to improve, but we never do the improvement bit of it because we get caught up and obsessed by project management, program management, highlight reports, business cases. Jettison that nonsense. It leads to nothing. If you were to apply that in your private lives, you wouldn't have a private life. If you carried out a risk assessment every time you wanted to go to a restaurant, for example, well then apply this in the professional world as well. Solve problems. Help people manage for greater independence. That's a key statistic there. It's a key measure. Not manage task activity. And lastly, reviews, which always get left and forgotten about because we don't have the time, become bread and butter to what you do on an hourly, daily, weekly, monthly, yearly basis. You stop that. This is the waste that consumes resource, demoralises people, both for service users, patients, and staff. There is no value in any of it. And I can expand more in the coffee break if you wish. I'm just going to touch on a few of them. Don't manage demand, understand it first. Don't obsess with things like internal referrals or assessments. Understand someone and commit to them delivering based on what they need. And when it comes to commissioning, move from contracting, which is what we do at the moment, to actually understanding that we need to think purple. Don't worry about whether the money is adult social care or the NHS, red or blue. Let's think about what we need to spend to give you a better life and to manage and treat you effectively. Improvement is about cohorting, okay? It's about trying different ways of working, applying a structured methodological framework in geographic concentrated areas where you know service users are. Designed to improve experience, provide continuity of care. We customise services based on your needs, not our convenience. If you do that, you reduce consumption. Consumption fell dramatically in this part of the world, as did total system costs. Went from a third to a fifth. And learn to improve and improve to learn. We took cohorts of 211 people, 40% of them were in one town spread across 2 GP practices. Now, who would have thought of that before we started this process? On average, they were having 6 interactions in a 2-year period, but that grossly underestimated some of the behaviours that we were seeing. And we did these things. We talk a lot about integrated neighbourhood teams. We actually lived and breathed it, working on the right people doing the right type of work, and joint commissioning and budgeting. This can be done if we want to do it, but it requires a mindset, methods, and effort. My reflections, and I will wrap up, that we need to think differently about system design. We need to think about putting the local first, moving away from an obsession on standardisation and centralisation and automation. It doesn't work. We need to commission based on what people's needs are, not task and time. We need to have measures that represent end-to-end and budgets that do the same. And the principles are really important. Have continuity, pull, don't push, and use your judgment. We have loads of very trained clinicians and allied healthcare professionals and social workers who are told not to think, but just to do and apply a protocol. That leads to the activity obsession disorder that you see. I'm going to wrap up. My conclusions are we need to move away from activity management But activity management is driven by the analysis of activity. We need to move away from standardised and specialised service provision, because that's all activity analysis and management gives you. What that leads to is fragmented, functional and reactive work. We're responding to you in crisis, episodically all the time. The consequence of all of that is systematic failure demand on a grotesque scale. For me, improvement starts with working on the right type of people, doing the right type of work in the right areas. It's not the NHS or public services so much are broken, it's the nation. We've got to understand that we need to think differently, act differently, in order to do better work that works to transform people's outcomes, healthcare and allied healthcare and public service professionals who do the work, and it will save all of us an awful lot of money. Thank you for your time this morning.
I can't be the only person who noticed the excoriation of standardisation and modernisation. Conor, you have the wind behind you. The government is moving us towards standardisation. Hamish, you're facing in the wrong direction and like to get your trousers wet. Sorry, I didn't see that should be here. There are, if we get to 150 rooms in a university hospital, there are likely to be service compromises, service disoptimisations that result from using those standard rooms. Is the game worth the candle? Are we going to end up costing ourselves more by having that level of standardisation than we would if we had a few more bespoke rooms?
Myself and Conor are coming at it from different perspectives. So I'm critical of standardisation. Standardisation works, but the problem to solve is you've got standard customers. I'll ask a simple question. In any of your spheres of work, where have you got standard customers? You don't have them in the NHS, you don't have them in social care. Talk about beds. I've done this work in large teaching hospitals, the Oxfords, the Portsmouths, the St George's. I've done it in small district hospitals as well. We obsess on bed capacity. We never stand back to understand, ask a simple question. How many people are in our beds on an hour, week, month, year, multiple years? And when you do that, you discover that for large hospitals, some of which I've just mentioned, that will see in excess of 200, 220, 260,000 unique people coming through it in any shape or form every year, the bed problem is about 1,000 to 2,000 people that are behind 40 to 45% of the bed stock. If I give you Oxford's example, which I worked with them years ago successfully, they had the worst delayed transfers of care in the country. That's a hospital that sees in excess of about 230,000 unique people, A&E, outpatients and everything in between. Do you know the size of the delayed transfers of care problem? It was on 1,900 patients. That was it. You can't standardise services because you're dealing with human beings. Talk about primary care. Done that work as well. In a typical primary care surgery that sees 10, 11, 12,000 patients every year, a third of the work will go on 200 to 300 of them in geographically concentrated areas. We've got to customise the service provision based on a localised understanding of demand, and demand is different in different localities. The problem I had to solve in the rural Berkshire in A&E in the bed stock was not the same at St George's. It was completely different. So standardise. If the work is simple, predictable and repeatable, you can standardise it. You can also automate some stuff as well. But if you've got variation and variety in services, and there is a lot in service environments, standardise at your peril, because you'll be paying for it down the line. I think about economies of flow, not economies of scale.
Thank you. Question, and then we'll come to you, John.
Thanks. Hi, Laurie Lee from Geisers and Thomas Charitable Foundation. I had a follow-up with Hamish, please. So your sort of diagnosis and prescription sounded pretty convincing based on whether data or personal experiences most of us have with healthcare, I imagine. But the idea of people-centred healthcare doesn't also feel new, and I wondered why you thought we continue to struggle for decades and decades to put patients at the centre of healthcare. And I also just wondered, one of the solutions that people sometimes seem to think of is that markets should be a solution to that, because in markets, customers are the centre. So if you think of healthcare as markets, then patients automatically would be at the centre. What are your thoughts on that as well?
Couple of good questions. I'll start with the second question first. Some years ago, Secretary of State for Health, by the name of Jeremy Hunt, talked about the NHS needing to replicate, do you remember EasyJet? Cheap cost airlines. That's copying without knowledge. The problems we've got in healthcare. Healthcare is a complicated service system. It's not complex, it's complicated. But it's considerably more complicated than airline or retail, for example. So I wouldn't copy. I'd think about, for me, improvement and transformation is how you think about the problem. So it's a mindset first. What methods you want to pick. I just gave some examples there. Data for me comes in two types. Quantitative hard data, that will tell you what's happening if you ask the right questions of it. Young man, you can fuse data systems quite successfully. It takes a lot of effort, and that's why we often don't want to do it, because we put it in the too hard to do box, but you can do. What you saw there, based on the West Essex work, was about 24 different data sets and about a dozen data systems. It can be done, we just don't need to think about it. I agree with you, first question, so to answer the second question. First, so it's a mindset and method, and then we'll get to the models. We have this obsession in this country that we've got to think about operating models, or we've got to think about outcomes, and we enshrine that in contracts, and we commission that. We never step back to understand who are those contracts, and what are those models designed to do, and who for? Yeah. First question. Person-centred care is not new, but we've been talking about it for a long time. It's like integrated care. It's like neighbourhoods. It's like the next fad. Again, how you think about the problem counts. In that example I gave, you couldn't possibly transform intermediate care for 300,000 people if you employ a few thousand. You just do not have the capability and the capacity to do it. But that's okay, because you don't have to. If you know that predictably every year 6,000 people, a really tiny percent, are going to be behind all your problems. And the focus on the vital few is because we've got to start to learn how to improve and improve how to learn and how to employ the principles of person-centred care, because for me it's a method problem, right? It's a mindset and a method problem. What I think I've heard today and what you've outlined has been this activity obsession disorder that we have, that we think we're going to solve anything by either doing more in one part of the system and less in the other. I wouldn't do that, because that will drive the NHS into the ground. And what comes after the NHS in the form of insurance is going to be even worse, I can assure you that. Does that answer that question? Thank you.
Thank you. Jonathan, and then at the back.
Thank you, Jonathan Eskin, European Health Property Network. But I'm kind of wearing a slightly different hat for this question. Thank you to all the speakers. It's another question for you, Hamish, initially, sorry, but perhaps also applies to everyone who spoke about patient flow as well. I think it's obvious, isn't it, that the problem is social care when we're talking about all of these things, and that your description of your method, Hamish, and your analysis was very clear, and the West Essex solution was very clear. But my question is, what was the magic element that enabled that to happen? Because I represent, as well as the organisation I mentioned, an Edinburgh charity that works in exactly the field you described, making life bearable really for older people in their own homes and in other environments. And we find it an immense struggle to coordinate properly with the local authority who holds some of the contracts, with other charities who we work with the NHS. And yet, what you described in West Essex seemed to have overcome that somehow. But what was the mechanism?
Really good question. I'll challenge you respectfully on social care being the problem. You hear loads of commentators, people like Roy Lilly, talk about that. I read his blog this morning. Can I be bold? He's wrong. Okay? Social care is not the only problem causing problems in the front. So let me just be frank. Because we don't understand our customer base in the NHS, take the acutes. The people that you see in the plan care system in elective care are different people from the people you will see in the urgent care system, because I've done this work there as well. The problem you've got at the back door is typically a frail elderly problem for the majority. The problem you've got at the front door is not. 50% to 2/3 of the people that are the high consumers of vital few are under 65. Okay, that's not commonly understood, and it's not chronic conditions driving that problem. It's a chronic service misalignment and design problem. Loads of failure demand because we haven't understood what we've got to do for you. Everything from someone coming in with a suspected fracture that will wait several hours, maybe be diagnosed successfully, maybe won't be, from everything from that to another person whose life is off the rails and they're coming in for the 80th time. I did this in George's years ago. The solutions were really quite simple, but you had to spend time to understand them. Your point about West Essex, there are 3 types of change, okay? And it comes down fundamentally to leadership and getting leaders to see that. So one form of change is coercion. Okay, it's my way or the highway. Trust me, I've tried that, and the only thing it results in is my piece 45. The second one is rational. Right? So I rationally explain that this is a better way from where we're going at the moment. That's what you heard me talk about for 20, 25 minutes. That doesn't win hearts and minds, does it? Because if you're mapping my stuff over to your mental model, you're either going to say, I violently agree with you, or I violently disagree with you. So the third tactic, which is not always easily achieved, but it's normative, okay, normative change. See by doing, learning. So that stuff that I talked about wasn't always me doing it. I got the leaders to come out to do it themselves. Let's understand demand at the point of interaction. Let's understand what we're doing that you're commissioning £25 million for. If you remember at the start of the presentation, I talked about a commissioner asking 2 questions. I told him to ask those questions. But it wasn't me asking those questions, because if I'd have asked those questions, we'd have got a different reaction in the room. He asked those questions, they fessed up and admitted, we've spent £7 million on a consultancy not to tell us what we need to know. Let's go and find out. Does that answer your question?
Yes, I'll find you in the coffee break.
Thank you.
Thanks.
We have a question at the back.
Thank you. Hi there. Hamish, this is a question for you about the vital few. So you spoke about them in intermediate care. Where else can they be found in the healthcare system? And my second question is, does it also affect the wider public sector and the private sectors?
So your question is vital few, where are they?
Yeah.
Everywhere. So if you drive an organisation based on activity obsession disorder, if you think the problem to solve is how many activities are going on and are they high or low, you're going to have loads of failure demand. I've done this work in primary care, as I talked about. I've done this work in beds. I've done this work at the back door of hospitals. I've done this work during COVID on elective care as well. There's a very good reason why these waiting lists, despite an awful lot of time, effort and money, are not going down. Do you know what that reason is? They're stuffed full of failure demand, because we're not asking how many times is it the same person on multiple waiting lists who we're having to do rework for the umpteenth time because we didn't get that hernia operation right, okay? Or they waited 2 years for a procedure which we elongated because we were told the protocol needs to be you do this first because that's standard, and you do that next because that's the standard protocol and pathway, when actually the clinician wanted to do the operation at the first port of call but was told that could be too expensive. And then we take you off a waiting list because we fudge the numbers that way to put you back on. I've done this in social care, children's, adults. I'm working right now in a local authority that thinks it's got a demand problem. It doesn't. It serves a population of about 160,000 people. The adult social care service user population is really, really tiny. It's 3,000 people. Those 3,000 people last year had nearly 10,000 commissioned packages of care. Most of them didn't meet their need because it's standardised. The financial consequence of that is that they're spending nearly £50 million on 3,000 people. Can we do better for less? Yes, we can. But we've got to change the way we think about the design, management and improvement of complicated service systems like healthcare and adult social care. Does that answer your question?
Yeah, thank you.